Good evening, everybody. Today I shall be talking on breast mass evaluation, mammography, ultrasound, MRI with histopath correlation at our hospital, Sir Gangaram in New Delhi. Like we all know, contrast-enhanced MRI of the breast not only defines cross-sectional morphology, but it gives us dynamics about the lesion. It lets us know about the tissue perfusion and the enhancement kinetics. And breast MRI has the highest sensitivity of all imaging modalities. It has a sensitivity of 89 to 100% in invasive cancers. We are working on a 3T vario system. This is what our machine looks like, and this is the breast coil where the breasts are placed. My first case, this is a 27-year-old female. She was a liver donor and came for screening ultrasound. She had no symptoms pertaining to the breast. On examinations, however, she had palpable lumps. Her mammogram showed dense breasts and nothing could be really deciphered in this. However, on ultrasound what we find are these well circumscribed, smoothly marginated masses. A few of them show a lobulated outline. And on MR, this is a T2 weighted image. We find these lobulated masses showing hypointense to a little hyperintense signal. The hypointense signal on a T2 weighted image is because of the sclerosed component. On contrast, what we see is there's a homogeneous internal enhancement, but what is characteristic of these lesions are these hypointense non-enhancing septae. There was no obvious restricted diffusion. On our colored images, you can appreciate the lesions better, and the dynamic mean curve was type 2. FNAC from this right-sided lump turned out to be fibroadenomatoid hyperplasia. Fibroadenomas are of two kinds, myxoid and sclerotic. The myxoid fibroadenomas appear hyperintense on T2. Here I would like to emphasize that most benign lesions are hyperintense on T2, sclerotic fibroadenoma being an exception to the rule. These are hypointense on T2 weighted images. However, because of the smooth, well-defined lobulated margins and not much enhancement, we can diagnose them as BI-RADS 2 benign lesions. My next case is a 57-year-old female who came with a tender lump in the right breast of 3 months duration. FNAC from this lump 8 years back was benign. On her mammogram, we can see this dense, slightly lobulated mass which shows well-defined circumscribed margins. On the corresponding ultrasound images, the lesion is well circumscribed, however it shows a heteroechoic pattern. On MR, this is a TIRM image, we see the lesion is uniformly hyperintense, but what we need to really appreciate in this is that the margins of this lesion are slightly irregular, and we can see these enhancing spicules extending into the adjoining breast parenchyma. Even the enhancement pattern is more rim-like with internal areas of enhancement. So even though it's bright on a T2, which puts it into a benign category, we have to be careful because the morphology is not that of a benign lesion. Even the dynamic mean curve showed a slow rise with persistent enhancement, which is type 1. So despite all these characteristics, we still place it in a BI-RADS 4 category because of the morphology of the lesion. This on FNAC turned out to be a colloid carcinoma. Colloid or mucinous carcinomas constitute 2 to 3% of all invasive cancers. The ultrasound and MR pictures are rather non-specific. On MR also we have to be very careful because the lesions show hyperintense signal on T2 and show benign enhancement kinetics. My next patient is a 40-year-old female who came with a palpable lump in the right breast of 2 days duration. Patient was lactating and complained of straw-colored fluid discharge from the nipple. On mammogram, we find this lesion which shows irregular margins, and on ultrasound, the lesion was hypoechoic, showed irregular margins and a small speck of calcification. On MR again, this lesion appears hyperintense on T2, but we will still not put it into a benign category because by the walls of the lesion are showing a hypointense signal And on enhancement, we find thick, irregular enhancement towards the periphery of the lesion. On the delayed contrast images, we can appreciate these enhancing internal septae. There is increase in vascularity of the right breast due to neoangiogenesis, and she incidentally even had significant axillary lymphadenopathy. So this was placed as a Barrett's 5 lesion. On diffusion, we can see the thick enhancing component of the lesion shows low ADC values, and the dynamic mean curve was type 2. She had a right modified radical mastectomy, and this was invasive ductal carcinoma with cystic degeneration. So now we have two conditions, colloid carcinoma and invasive ductal carcinoma with cystic degeneration, which can appear hyperintense on T2, which normally only benign lesions appear. My next case is a 24-year-old female who came with heaviness and discomfort in both the breasts and significant increase in size of the breast for the last 1 year. Her mammograms showed very dense breasts and nothing could be picked up. On ultrasound, we can see a heteroechoic pattern of the glandular tissue. On MR, there is diffuse enlargement of both the breasts. It's very symmetrical. There were these benign, mildly enhancing lobulated masses. Otherwise, there was no increase in vascularity of the breast and no other obvious mass lesion. This turned out to be juvenile hypertrophy or benign virginal hyperplasia. This occurs in a relatively short period of weeks to months. It is an abnormal local reaction to normal hormonal levels, often begins shortly after menarche, but can even occur during pregnancy. And the breasts are normally symmetrically and diffusely involved, but the disease can also be unilateral. On histopathology, there is dense connective tissue surrounding the ducts and absence of lobular development. My next case is an interesting case. You can see the skin was all red and there was areas of excoriation. On mammogram, the breasts were very dense, but we can pick up an ill-defined lesion showing irregular margins, and the corresponding ultrasound images showed this thick wall lesion with internal echoes. On MR, this lesion showed peripheral enhancement, and on T2 weighted images it appeared hyperintense. There was another lesion which was hyperintense on T2 and showed mildly restricted diffusion. Apart from this, we can appreciate as a thickened skin, which is well appreciated on the colored images, and there were these multiple coalescing abscesses superiorly with central areas of non-enhancement. The dynamic mean curve was type 2. On surgical biopsy, this turned out to be tuberculosis of the breast. In these conditions, it's very essential to differentiate them from inflammatory breast cancer because the MR findings can overlap a lot. However, in acute mastitis, the abscesses normally appear hyperintense, whereas in inflammatory breast cancer, there is extensive desmoplastic reaction, so there is hypointensity on T2 weighted images. And normally the curves in acute mastitis are type 1, whereas in IBC they can be type 3. But like I mentioned earlier, there is significant overlap, and if there's any doubt, a biopsy is mandatory.